I'm really pleased now to announce that we're moving to the next session, and the next session is on pretty much, one of the tools that we have discussed on reducing unmet needs, which is the role of community-based care. And this is quite an interesting session. We're actually going to focus on what we have thought and have come across as innovative models and approaches to community-based care. And here we're trying to be a bit future-looking, moving a bit beyond very traditional approaches of very regimented home help that comes and just does one or two tasks and goes away. But we're looking at more imaginative and more really community-embedded sessions. And our first speaker is going to be Henk Nies, who actually has a very important role in the Observatory because he has agreed to chair the executive committee of the Observatory and helping us give more shape to this initiative. And he's going to talk to us about innovative approaches to community-based care in the Netherlands. So Henk, the floor is yours.
Yes, thank you very much, Adelina, for introducing me. And I'm happy to have I'm honored to have the opportunity to speak with you about the innovations that are upcoming. And it's not only new innovations, but also a little bit of old innovations that we see in the Netherlands regarding community care. Well, I come from the Netherlands, as you can see, and the Netherlands is a highly professionalized country. We spend the most money on long-term care in the world, I suppose, as a part of our gross national product. But we see the last few years that there is a huge development in community-based care. And the reason for that is what has been noticed in previous discussion, but also by WHO, that long-term care challenges need a societal embedded approach. It cannot be solved by developing a long-term care sector as such. It needs to be aligned with many other sectors of society. And what we saw in our country is that we have, of course, like many other countries, shortages of professional care workers. We see also a high pressure on informal carers. But we see that at this moment, we see many communities coming up and taking care of long-term care issues by people. And that is mainly done by looking at how can we ensure a good life. Long-term care is not so much about repairing and healing, but it is about providing people a good quality of life. And we, since about 15 years, we saw what we call caring communities. Unfortunately, I just have this picture in Dutch, but we have around, this is a picture of 2020, but we have around 2,000 local communities, organizations of citizens who are doing volunteers work together, sometimes supported or often supported by a small percentage of professional worker who helps to organize the community. But in most cases, it's the communities themselves who organize activities such as meetings, meeting centers, neighborhood assistance, bringing people to hospital if needed, having to join dinners, taking over a local restaurant by volunteers if that couldn't survive on its own. So it's very much organized in terms of citizen involvement in creating a good quality of life in the local community. That is in rural areas, for as far as we have rural areas, but and the idea is that it should have the size of a small village, about 5,000 inhabitants. But it's also in large cities. In Amsterdam, for instance, you have about 30 of these communities, and they call themselves city villages. The idea is that, well, within a community of 5,000, there's a big chance that you can know each other. So that has been developed. It has often a formalized structure, but not always. and it works with many volunteers and with some charity funding or funding by the municipality, but money is not the biggest issue. We also see interest in housing and developing these physical infrastructure combined with the social infrastructure. And this is a so-called discussion picture by the Dutch Alzheimer Netherlands organization. And they depicted how it looks like to live in a dementia-friendly community. And what is good for people with dementia is usually good also for all other people. The reverse is not true, may not be true. What you see on these pictures is a housing accommodation with a meeting center below, and there are specific requirements in terms of technology and lighting, etc. in this housing accommodation. There's a place where people can meet, but there's also outdoors activities where people can meet. There is a so-called care farm. I will spend a few words on that later on. There's health facilities. There's a supermarket which is dementia friendly. So you should think of making an environment which is which welcomes people with dementia and who can have their meaningful activities. That's the idea, and it is being realized in many places, parts of it. And the point is, how can you make an integrated approach to this? One of the recent developments we see is in fact an old development. It stems from this 15th, 16th century already. We had so-called hofjes in cities in particular, where poor older people could live together, financially taking care of the rich. And it were in fact square-like small dwellings with a square in the middle or some green in the middle where people could meet and they could look also after each other. And we now see that new houses are being constructed where this idea of a hofje is being practiced in these times. So people are living there with the idea that they can look after each other, can have nice activities with each other, they can have meals together or can garden together or whatever is needed. So it's about normal life, but if needed, they can give some support to each other in addition to what professional support can mean. We see also that intergenerational housing gets more, is becoming popular. This is pictures from a residential home, in fact, where they rent rooms to young students or young people for whom housing is at this moment very expensive. So they get some living facilities in a residential home for a reduced price, provided that they spend 10 or 20 hours a month on volunteers work with the older residents in that particular house. And it works pretty well. And it's they're not counting the hours. In fact, usually they have just nice interactions and nice communication with each other. We see in these neighborhoods also an upcoming development is precaution cycles, as I would translate it literally. The idea is that approximately 12 people, more or less, have a circle, and 2 of them are the contact persons. They are in the middle, and they are appointed as the persons to whom you can ask questions or to whom you can offer services. People should live in this type of circle in the neighborhood. That means in walking, or in the Netherlands also at biking distance. And if the question is complicated or complex, these 2 connecting people can go to a volunteers organization, which is organized as a volunteers organization, or to professional care. And it is in fact, it's a very simple method. And as far as I know, it works very well. The healthcare insurers are encouraging this because they might have also some benefit from that, but they also think it's important to organize society. Another one is dement talent. That's in fact, people with dementia are on average between the moment of their diagnosis is being set until they die. That's a period of on average 7 years. And in these times, in these years, they have plenty of time to live a good life, but and they can be meaningful. So this Demand Talent project employs them as volunteers on various projects, and people find it great to be a volunteer because they can be meaningful to other people and can live a meaningful life. What is also important is that society is open to people with dementia or vulnerable older people or people who just need a chat, want to chat. So we see supermarkets with a slow lane and with chat corners in the supermarket. And the slow lane, you can have a chat with the cashier, or you can have a chat with the other ones in your lane. So you don't have to rush as in usually in supermarkets. And there's also small coffee corner where you can meet. And well, it's a small thing, but it works. And these people who are working in these supermarkets have had a slight training in how to interact with people with dementia and older people in general. We have about 1,300 care farms in the Netherlands. So farmers who had some issues with continuing their business, but also farmers who thought, well, maybe farming is also good for for other people to participate. They organized so-called care farms. And these care farms are not only for people with, are for people with dementia, but also often for people with long-term conditions. It can be a mental disability, it can be mental issues. There can be various issues for these people, but they can work on this farm, they can meet each other, they can engage in meaningful activities. And what I said, 1,300 have been developed at this moment, and there's quite some evidence that it really has a beneficial impact for the people who are visiting these services. The Alzheimer cafes, that's really an old innovation. They exist for 30 or 40 years already, and they are also in some other countries, they work according to these principles. One evening a month, people with dementia, their caregivers, informal, sometimes also professional, meet each other, and they get information and can socialize. We have also quite a great number of meeting centers, which also have been proven to be very helpful to postpone, for instance, admission in nursing homes, etc. 200 across the country, and that's the red ones. And we have the so-called Odense houses that are walk-in centers. We borrowed the idea from the city of Odense in Denmark. And that's about 60 of them, and they're rapidly developing. Technology plays a part. I just pick out the picture right below. That's a compass. There's just only a prototype exists, but it's a compass that always points to your home. So it doesn't points to the north, but to your home. So that's an idea that people with dementia who cannot find their homes, when they have this compass, they can come back home safely. Finally, how to achieve this? Because it's a huge number of examples, and there's certainly many, many more. But what the idea is that what makes it work is that people feel solidarity between the young and the old, and the old and the young, but also within the older age groups. Older people are also a resource for support to each other. And they're not only dependent, they're not only vulnerable, etc., but also they have strength, and you address the strength of older people themselves. It should be organized within local communities, small scale, as I said before, and it can involve informal public and private stakeholders, the supermarkets, the restaurants, whatever you can think of. They also are happy to participate in many cases. So it's not only, and they feel solidarity with their local community. If you make it the scale too large, this solidarity feelings don't work. It is on many spots, many types of projects, many small-scale initiatives, and if you organize it in this way, it is possible to develop a sort of community initiatives which cover many needs. It will not be sufficient to answer all the long-term care needs in society, but they are very helpful, and many small units also add up to a big movement in total. And what we see is that the government and that governance should be very supportive. So very small subsidies by municipalities or by healthcare insurers can make a huge difference, is what we see. And they should not take over the governance of these initiatives, but let it to people themselves. Well, that's very briefly sort of an overview of a huge selection of community initiatives, and I hope it inspires you, and I would say pick out the cherries that might be useful for your situation. Thank you very much.
Thank you so much, Henk. And one thing we know is that ideas travel across the world. We just saw an example of the Odense Farms in Odense Center houses in the Netherlands. And now we're actually going to hear about a model in Barcelona that has been inspired by some Dutch experiences. So I'm going to hand over to Míriam Montané from the Municipal Institute of Social Services in Barcelona, who's going to talk to us about something they call the super islands, and you'll understand more about what that means in a minute. All yours, Míriam.
Okay, thank you very much. Good morning, everyone. And I will make the presentation. I will try to present this new model of management of home care service in Barcelona and the importance of the proximity teams. This is the presentation. What is home social care in Barcelona is the care provided to a person in the place where they live at any stage of their life, with the aim of maintaining them in their usual environment and achieving the highest level of quality of life, well-being and autonomy. We have two kinds of target persons, 84% in people in situation of recognized dependency, and 60% of individuals and families in situation of vulnerability. In 2023, we have average more than 21 users of this kind, 21,000 users of this project, and more women than men, and more people over 65 years, and about 4 million of hours of set. The goals are, I will not enter, but I think this is the starting point, because Barcelona is getting older, and we have nearly 350 registered residents aged over 65 now, and 13,000 places in senior citizen residence, but a waiting list of 6,000 people. And we have also information of socio-demographic surveys that about 100,000 people in Barcelona who need help with their everyday activities. This is the question, or led me to the question of we have a problem or an opportunity in Barcelona to get it better. So when the new government 2016 entered in Barcelona municipality, they wanted to see other kinds of models of set, so that they can structure differently. And the phased step was the next one, please. The initial, the next slide, thank you. The initial the before, exactly. The initial diagnosis, this is the starting point. They saw that the prescription of closed hours, commitment from the prescription that leading professional, quality and attendance and punctuality. Our work organization was high hierarchical and individual, and for this task, we have also a concentration of service hours between 8 and 12 was the most concentration. In addition, all kind of labor tensions because of the partiality, rotation, physical and psychological burdens, substitution, a lot of travel times and absenteeism, and also increased cost because of overage people getting to this program. So the objective for the future SAT that was settled was to improve the working conditions, reduce precautioners, the working hours, reduce travel, supporting teams and all, and to improve the user certification, to make teams of professional visible in the community and facilitate synergies with the rest of the community agents, especially in health, to increase social recognition of care and citizens, to have an inclusive vision, and finally, but not least, the importance of the actor involved in the community. So with this idea, the first step to make a new model that we adapt from Netherlands, in this case from the Buurtzorg model, was, if you want to get the next slide, please. Okay, thank you. There's the solution where the new model based in creation of teams of professionals who attend to a group of users who live in superblocks, set of proximity, we said here in Catalonia. There are urban superblocks in a territory of proximity, physical defined by a set of blocks of the urban fabric with a population between 5,000 and 8,000 inhabitants. And the social superblocks pursue the idea of distributed or virtual residence. The neighborhood provides all the common services that are provided in a residential area with a radius of 300, 500 meters, depending on the place or the territory in Barcelona. So the characteristic of this new model is to have a team, and this adaptation from the Buurtzorg model in use in Netherlands. It's a flexible territorial unit, and normally between 40 and 90 set users. The hours for service per week average 300, and they must be in the same social service center and in the, if possible, in the same area of basic health area. And so what we need also is a physical space to hold the team minutes and workspaces during the service outages and to make changes. So we can get to the next point, please. To build a team, to make it all, we need to start up. And first point is to select the territory. Usually is the indicators are like density or over age people. Then the next step is making a study, quantitative and qualitative, of the users and service to see if it's we can do it. And then the critical phase is when we make the next steps, team building. And here we need a lot of different small phases to identification of the physical space where they can hold their team, the communication with the professional of the team, the communication to representing profession of the Center of Social Services, the training to share the vision of the model, to start up the superblock. And when they are start up at the beginning, the meetings are bi-monthly and then once a month, so that we are stabilizing the teams. Then we have to do the communication with the users and families, the planning and sharing complex cases and working to improve services. And this is the beginning from the model. And now I will try to contrast the territorial model to the innovation model. Is the next slide, please? Okay, so the innovations are that the person is cared by their family workers and by the rest of the profession of a team who they know and identify from the beginning. They get a kind of documenting with a photograph and a telephone number so that they can call them. So if somebody else come to the place, they know them. The person is also informed in advance of the flexibility of the service and the communication channels with the team. The third point, important point, is the teams are made up from 10 to 15 direct care workers, and we have a technical coordination person that makes kind of, yes, if there is a problem, or it's a kind of coach for this group. The team as a whole is orientated towards a self-organization, and this implies the need for all the team members to participate in all assigned tasks and requires greater coordination, and also implies the follow-up of the users and the contact with the basic social attention team to transfer information. Here I have to stop and say that a lot of self-organization tasks now it's not possible because we have some complaint with the trade unions, so we had to get other ways to get this kind of self-organization tasks. I will not enter exactly, but only to say that we tried to do it, but it was not possible in a few of these tasks. So finally, the teams act as a cushion or buffer for the workload that some services entail in the contractor, and the contractor assumes the commitment to increase the number of full-time employees. In the next slide, we see what is now the new SAT model. We have 92 proximity superblocks with 40 to 90 users SAT, what means that we now have 35 of the people in this kind of model, and the rest is the traditional model. So what is good of this model, or what we think direct workers help us to make other steps in for community, but also for other experiences. That is the next slide. Here we have a new experience of proximity teams with healthcare. It's a new way of working for social and health team to improve care for citizens. Is a care in which professionals from different services have the same objective and incorporate in shared decision-making the person and the care environment. So what is important here is the core project is the communication of the family worker with the doctor nurse when they see signals of risk, or when the family workers is the only contact person of the user of SAT. Now we have 2 pilots in different parts of Barcelona. One who began 2018, and with 3 superblocks and 200 citizens. We are in the final phase of 2, and a new one that began this year with 4 superblocks, 250 citizens, and we are in the beginning of the phase 2. If you want to get to the next slide, I will not, here there are all the phases. I will not explain everyone, only to say that we are in one CISCUCHERAS, we are in the planning of joint meeting between the health referent teams and SAT teams in each Iceland. That means that they meet each other and speaks about the user of SAT, so that if they need something, they can make it together. And for the other team that is new, the GAP-plot, we at the beginning, so the presentation of teams and the training, so that they can see what kind of risk people can have and transmit this to the nurse or doctor. These are some results. We think we go directly to the user. The reference of the team becomes Superblocks team, communication and change. They have a contact telephone number, so it's faster, the communication, the incidents can be very fast, make, and the programming also, or the schedule, they can, it's a flexible schedule, so if they need more hours or more teams, they can go there. So next slide, what we need for the model to work. There are a lot of things. I think one of the big problems is the dynamics of incoming and outgoing services. Also, the accompanying services outside the blocks, the service with timetables, the to prescribe services and weekends, the complex services, also problems with the family workers, like fatigue with family workers and digital disconnection. The territories with low density, we haven't make nothing in this aspect, but we need to do it if we want the Barcelona to have all supermodel in this new model. We need to homogenization of the model. We have some problems with the coexistence of the two models, and we have to adequacy of establish for the company have sufficient time, and finally that the communication is better in the community network, and but finally the mixed financing, so that the increased cost we can have it better. And yes, to sum up, the last one, please. Okay, the elements we do value most is the teamwork of professionals, the direct communication between users and team, and the matching of social and healthcare teams. So I will thank you very much for, I think I had some slides more, but this is the time I had. Thank you very much.
Thank you so much, Míriam, and it's great to have an insight of the experience of implementing this. And we're now going to actually we're going to another part of Spain. We're going to the Basque Country, to the Diputation of Bizkaia, where Lourdes, and I'm not going to say her surname, and you will see why, is going to present on a model called EtxeTIC, which is a new paradigm of community and technological support for staying at home. And Lourdes, if you want to present.
Okay, good morning. Thank you, Adelina. I am Lourdes Zurbanbeaskoetxea. I am the coordinator of a transition plan for long-term care in Bizkaia, in Basque Country. And well, first of all, thank you very much for the opportunity to participate in this event and tell you what are we doing in Bizkaia. First, next, please. Okay. I would like to briefly contextualize the project into the transition plan we are working in Bizkaia. We see this transition plan like as an instrument to promote innovative public policies in the face of the social challenge of care in Bizkaia. And we start with work with an European experts team. You can see the document, Bay of Biscay, Bay of Care. And you have the link if you can see better. The transition plan is based on a set of pillars to move towards a care model based on people's rights and person-centered approach. These pillars are not only about people at home, but also about developing smaller residential units with a home-based approach that allows for care focused on what is significant for people on their quality life. And another fundamental pillar are the regional reference centers with specialist support teams that accompany and advise the residents of the path towards personalization. Next, please. I think it's very important to say that the CAR model starts or is based on reflection on the ethical foundations of proper care. It's important the center in our responsibility of the generation of opportunities for a life achieved that deserve worth living. In short, we are talking about a model that satisfies the recognition of rights, a model that generates conditions for the participation of people in the community, and a model that enables support for a personal and meaningful biography. Next. Focusing on support for home-based care, some steps were already taken back 2018 with the publication of the decree that includes the statute for caregivers. It establishes the rights and duties of caregivers and, above all, recognizes their status as caregivers. And we think that it is a very important thing. And there are the rights that are established in that decree, right? The right to rest, the right to training, the right to have an adequate information and care, the right to access and assistive products, and the right to social security. Next, please. Moving to now on the EtxeTIC services to support people staying at home, this is a driving element of a model of preventive community intervention focused on the person and their environment, a service that promotes personal autonomy and social participation and facilitates access to other resources in a coordinated manner. How is this the process? Well, starting with from a personal history and values, I think it's very important first, and then a comprehensive assessment of capabilities and needs and support preference for the person and the caregiver, both. So it's about proposing a support plan focuses on the care ecosystem that is both on the dependent person and on the caregiver or caregivers who provide the support. It is also important to emphasize the existence of a professional of reference in the center for all questions. Although sometimes the response may require the presence of another professional, since the center has an interdisciplinary team, psychologists, nurses, social workers, and etc. The services is provided with the support of non-invasive technological devices in the home that allow support in care and also prevention and detection of risk. That technology allows to increase the number of people assisted. The main support is very simple. It's a tablet with internet access. And the tablet itself allows to contact with the professional of reference, to carry out exercise that have been previously agreed with the person or the caregivers, to receive personalized information related to their support needs, about their pathologies, etc. Sometimes they also rely on other devices, but very, very simple too, such as movement clocks, for example. And think two another important things. Obviously, support for the use of technology
They can't hear me.
is two. And another thing that is not essential to use a technological tool to receive the service, because it can be difficult for some people. And I think another thing that people values is in addition to technology, the possibility of timely in-person assistance and care at the center itself. So it's combined to both of these. Always this assistant is extend that people need it. The frequency, activities will depend on the support plan that has been agreed upon. Support at the center itself is provided through training boards, respite programs, and these respite programs enable carers to have free time, knowing that the person in need of care is being cared for at the center itself. It's very, very important for the carers. Next. The objectives we set for ourselves when starting the services were improve the quality of life of EtxeTIC. Previous, yes. Improve the quality of life of EtxeTIC and sub-EtxeTIC for the people in situation of dependency and caregivers. Reduce unwanted institutionalization, and also reduce as far as possible the rate of overload of caregivers. And we said previous that it was with support plans for the home-based care ecosystem with personalized action, with a specific training action for caregivers, and guidance or different efforts or respite for caregivers. And also very important, identification of a specific action that contribute to the co-responsibility of care from a gender perspective.
Lourdes, we have about 2 more minutes.
Yeah, okay. Next. Okay, bueno, now we are with a regional extension to the finish, to the end of this year. We have 11 centers in all Bizkaia and 11,000 of potential users or potential homes better. Next. And what are the key elements, no, of this service? Well, it's a proximity center, like you can see. Telematic support is combining with assistant to the center, occasional assistant to the center. The care is for dependent people and caregivers. Is a service that is free of charge. Serves people of all ages, children, young people, in the different situations of dependency or disability. They have a reference, a professional of reference to facilitate access to coordinated resources. And I think it's very important that technology is an opportunity and not the end. Next, please. Obviously, technological innovation is necessary, both in the development of platforms to facilitate interaction and the development of information management and analysis system. And the finish next, last. Okay. And finally, I think it's very important to say that a good coordination with the health system is necessary to advance in the transition of care. I think one of the keys are the establishment of a specific governance model with the involvement of the health system and social services at the different decision-making levels. And we have a work in common that is Bizkaia's Health and Social Care Operational Plan. And there are 19 operational projects, and there are some that are specific to home-based care projects, like integrated end-of-life support at home, or the development of the case coordination model, among others. So, eskerrik asko, thank you, the last. Thank you very much.
Thank you so much, Lourdes, and apologies for rushing you. We are running a little bit late in this session, but we were very ambitious because all of these models are so interesting, and it's fantastic to see here how these services are integrated with the community. And the next speaker, we're going to go to Brazil. We're going to hear from Karla Giacomin, and we're going to hear from a really, really interesting program they have developed on integrated care in the community. Karla, it's all yours.
Okay, thank you. I will share my presentation. So I'd like to thank you for this invite. And we are completely changed of the world, okay? Because now we are talking about inequalities. My country is a huge unequal country. And as you see, when we talk about long-term care, we should talk about different care settings. And we will talk about the lowest or the less favorized setting. That's what I will talk with you. I will share with you a community care in Brazil. And Brazil has 210 million citizens. And we have now 32 million people aged 6 and over living around the country. And this is Belo Horizonte, where we developed one successful experience of integrated care at home for 4 older people. Belo Horizonte is the capital of the state of Minas Gerais. We have 2.5 million inhabitants, and then 30,000 older people. But, however, as any big city in Brazil, we have also high levels of violence, fueled in part by the illegal drug trade, present another important health challenge. So the most green areas of this map is also the those who which have the largest elderly people in the city. Okay, in Belo Horizonte is we have an incipient development of formal long-term care service, and we are focusing on residential services with little integration with health services at the community level. we have social assistance system and we have a health system. Each red point is a center health, a primary health center, and each house here we have the reference center of social assistance. So the common challenges are facing aging in a context of huge social vulnerability. This is the program context. We can have here in this QR code a publication of the IADB is in English, but we have also in Spanish version and a Portuguese version. And now we are talking about the main stages of the program. We have a close coordination between different agencies, including the Municipal Offices of Health and Social Assistance. And we offer trained care workers paid to spend 2 to 4 hours a day with target households. And these households are selected according to the level of care dependency of the older members, socioeconomic status, and other indicators of family vulnerability. It means that PMC, the Programa Maior Cuidado, emphasizes collaboration between care workers and family members to meet the older person care needs, develop the knowledge and capacity of family members to perform this role independently, and agree customized care plans. PMC care workers conduct regular case reviews in joint meetings of health professionals and social workers. But why are we talking about this? Because this program is based on 4 characters: the social assistance, the health, the civil society organization, and the older person. Social assistance and health are responsible for insertion, monitoring, and training carers. The civil society organization hire caregivers, and the older person need to fulfill some features. So they are vulnerable, even social and clinical and functional level. And the main objective of the program is to prevent situations of risk of social isolation and to contribute to avoiding, postponing hospitalization and also referrals to long-term care facilities. And the stages of the program begin with the identification of the older person, who should be dependent or semi-dependent and should live in an area covered by the social assistance system. The insertion of the case is discussed after the completely insertion documents, and then we fill out the care plan. And for supporting these caregivers and this family, we do some home visits and we participate in the case reviews. And the discharge, the most reasons of discharge is death. 49% of the older people are discharged by death. It means we care up to the end. We improve the family bonds and we help to organization of family care, and there are other reasons of discharge. This program have been evaluated in many kinds. So since this implementation in 2011 up to now, many agencies and universities are evaluated this program. And now we can share with you some evidence of this. So the Maior Cuidado, this program, improves the quality of care provided by family, reduces caregiver stress, and empowers families to care. We help people to access to consultations, because when we are being assisted by the PMC, we have a higher proportion of planned consultations, and we have access to outpatient consultations for rehabilitation purposes. We avoid efficiently institutionalization, and we really save resources, an average saving of 34% in hospitalization costs when we compare PMC and non-PMC users, and we help to a more efficient use of health resources. And finally, we have, when we asked to health professional in 9 focal groups, this is the cloud words, and we can see only positive words about the program. And for my final remarks, another signal of the good practice of PMC, that it continues through 5 different municipal administration, and we can share with you some comments in the meetings. We can see the difference PMC makes before and after people are included. It not only prolongs life, it brings older people back to life. And another one, we have been able to see the results of PMC for ourselves. It's really clear, especially how it affects the lives of family. It's so wonderful to see the relief PMC brings when a family carer tells us she now has time to wash her own clothes and do more things for herself. Before she had a PMC caregiver, she had no time for anything. This is so gratifying, before it shows me that the program benefits everyone. So these are our reference, and we can see many QR codes about the program too. And I am really appreciate your attention. Thank you.
Thank you so much, Karla. This is a fascinating project with great work as well, evaluating it and sharing lessons. We will share the links to the resources that you mentioned when we share the videos of today as well. And if you are happy for us to share the slides, we'll do so too. So I think there's a lot to learn from here and from many countries in the world. And now we're going to Singapore. We're running a bit late, so we might hit a little bit into our break. But Hiroshi, we really want to hear from you in Singapore. So the floor is yours.
Thank you, Adelina. Nice to see you again. It's really my pleasure. Good evening, everyone. I'm from the other part of the world, so it's 7 p.m. for me. I promise I will be very fast. I would like to just talk about the case of Singapore. Hopefully this case will be helpful for our discussion. My highlight will be on the integrated care in a community level and the role of NGOs in Singapore. At the very beginning, I would like to just make it a little bit broader for you to understand the rationale of Singapore in terms of social policy. Singapore does not have a welfare state. I mean, everyone is supposed to save for him or herself. So this is a kind of a system. We call it a Central Provident Fund, CPF, which actually it is basically a compulsive saving account for everyone. And then the government manages this account. And they have the responsibility to generate revenue to grow this account. And the second general background is that Singapore has some very general rationales about how to deal with population aging. In the late 1990s, actually, Singaporeans proposed this idea of successful aging in Singapore, highlighting on the intergenerational harmony and cohesion. But the most important approach is many helping hands. If you are familiar with the Asian context, actually, many governments, many countries in Asia are trying hard to rely on family and household to take care of their older generation. That's also the idea of Singapore government in the late 1990s. But with time passing by, you can see something has been different. I'd like to give you a little bit more background to understand the Singapore system. I mean, during the 1980s, Singapore is trying to reform its public health system by privatize or corporatize the public hospitals to promote competitions, basically. But just after a few years, the government changed its mind. They find out that market forces alone will not suffice to hold down medical costs. Therefore, a series of government intervention were introduced. In the 1990s, the government actually took those measures more in a more delicate and more complicated way. They are trying to promote the desired behavior in the hospital management. Okay, these are the general background. I want to talk about integrated care in Singapore. As you can see, this is the major agency in Singapore in charge of integrated care. It started from 1992. At that time, this agency is in charge of coordinate and facilitate the placement of discharged older patient from the hospital. But gradually, in the new century, you can see it has been renamed and was assigned to take a charge of the whole integrated care movement in Singapore. What do I mean by that? First of all, the first initiative for integrative care in Singapore is to organize the so-called regional health system. Singapore is a small island, and it has 11 public hospitals, 26 polyclinics as the government subsidized comprehensive clinics at each of the regions, and then over 2,000 private GPs, clinicians, the private general practitioner across the island. And Singapore tried to kind of cluster them and based on the secondary and tertiary care in partner with the primary care provider and then the long-term care providers, as you can see from this picture. And this has been monitored by the government. What will happen is this. As you can see, from 2008 to 2018, Singapore moved from 6 medical big clusters now to 3 big clusters. And not only that, not only they integrate the health care system at the hospital level, but more importantly, they started to integrate hospital and community. As you can see, there's initiatives to integrate the cluster from the tertiary, secondary level to the community and residential level. By that, I'm going to give you a very short story. You can see the central area of Singapore, which is in charge of the National Healthcare Group. Okay? Can you see it very clearly in the central part? It consists of a central hospital, which is called Tan Tock Seng Hospital. And then under this hospital, there are 6 polyclinics. And you can see other 2 hospitals with different polyclinics under its charge. And this is the story of the Tan Tock Seng Hospital, trying to build the so-called community of care. According to the webpage, COC, community of care, means we're going to set up an overarching framework to integrate all the local providers in order to deliver the holistic health care and social care. How can we do it? It needs to have an anchor partner, which usually is the NGO. Number 2, we need to have a community health team which is sent out by the major hospital. Third, we need to have the preliminary primary care providers like the GPs and polyclinics. We need to also have the community partners, especially the volunteer organizations. And lastly, we need to empower the residents or the so-called peer support leaders as the grassroots force. So the procedure looks like this. First of all, the hospital set up the health care post in the community. The co-location of this post gradually started to evolve into the bilateral referral workflow between the CHT and then the other stakeholders in the community. And then it will mature to set up a framework, and some very concrete project has been perlighted and then expanded to integrate those healthcare providers more effectively. As you can see, this is a general visualization of the whole idea. The CHT is sent out by the hospital, and then the anchor partner usually is the major NGOs, has been already invested a lot in that community. They cooperate together with the primary care provider, together with other organizations in order to make the so-called model of community care. This is my last slide. This is very recent. In 2003, Singapore promoted this to another level. There's a national movement called Healthier SG. And this is really to practice the rationale of preventive and integrated healthcare. I would like to briefly mention about the 5 principles. Number 1, everyone needs to have a family doctor to deliver the preventive care. Number 2, everyone should have health plan, including the lifestyle adjustment, regular health screening, and vaccination whenever needed. Thirdly, we need to activate community partner to practice the community of care model. And number 4, we need to have a national enrollment exercise to get everyone to be motivated to join this. And lastly, technologies should be used. We should highlight enablers such as manpower development and financing policy. Thank you very much.
Thank you very much. Now that has been a fascinating 5 presentations and very, very different ways in which of course, care is organized, financed, and developed in each of the locations. And it's great to see this very integrated model now in Singapore. Now we're going to have just 5 minutes for questions because we will need a break. So if anyone wants to raise their hand or pop up questions in the chat, you're very welcome. You can also share any links to to anything that has been presented as well. And what I can also do is, I don't see questions yet. Let me see. But what I would like to think is, now that you've had the chance to hear the others, I was going to invite Henk, if you're still around, if you could just give us a short reflection on what you have heard, Henk.
Yes, well, very, very interesting, and to see how the various models have worked out, are working out. I was fascinated by the Singapore story because it looks as if it is so very well planned with an idea behind it, and well.
Well, Henk, you know we're small.
Yes, that's an advantage. And what is also intriguing me, that the geographical aspect of all the various projects that we've seen, to define the area in which you are working and to make combinations of professional care and society and informal care and society is working in all these examples that we've seen. So I think that we have seen a number of basic principles that are applicable, and we are in a very different stages of development and if you're too much advanced, I would say that cannot be a disadvantage. So maybe if you can build up from scratch on, that might be a good opportunity to organize it in an appropriate way. So the Brazilian and both Spanish examples were also very interesting to see how you build up, restructure, and make the best of the professional, the informal, and the societal, the community care. Thank you.
Thank you, Henk. I see a question from Ruth Melo for Karla. Whether you believe that expanding PMC or similar programs to the national level would be possible without regularizing the caregiver profession?
Thank you, Ruth, for this question. Indeed, the society is not waiting for the resolution. So the society needs the caregiver, and we are also fighting for this regulation of the profession, but I think it's not a problem. I think it's not an obstacle for the program.
Thank you. And I saw a hand, but it's gone, so I'm not sure. Yeah, Elisa, yes, you can make your question.
Thank you very much. First of all, congratulations to all brilliant initiatives. So, but I would like to ask about the plan for sustainability of these models.
That's a great question. We don't have time for more, but we will, if each of you, of the speakers, gives a quick answer, and then we will give ourselves a little break before we go to the next session. So let me see, Henk just spoke, so I'm going to go first to Míriam. Míriam, you want to discuss a bit on the sustainability of the model?
Okay, we have some, money from the government. So there is a part of this services that are we are not paying directly from the municipality, and also there are some financials, like for example the travel cost that with the teams and they are nearby, it's going to decrease. So we finally we have a decrease of the cost of this kind of model. It's short.
Thank you, Míriam. Lourdes, you want to say a bit about the sustainability of the EtxeTIC model?
Yeah, she's Nayara with me.
Hi, Nayara.
Hi. Just a brief comment. We believe that we should implement some research work to assess what are the actual outcomes of these models in order to decide if they are cost effective or not, if they make sense in our context. Hence, I think there's a lot of work to do in that sense, and it will be interesting to hear about the other experiences, what kind of frameworks to assess their systems, not only in terms of service provision, but also in terms of impacting well-being. So we would like to do some research in that sense.
Thank you very much, Nayara and Lourdes. Karla, on the sustainability?
Yes. The PMC is a very cheap intervention when we compare to the long-term care facility, for example. And in Brazil, we are preparing our first policy, national policy of care. So we suppose that this model could be used for this national plan.
Thank you. And Kifi? And I think I'm not pronouncing your name well.
Yeah, sorry. Call me Feng, very easy to pronounce. Yeah, I just have very briefly 2 points. One point is the very reason Singapore government try to do this kind of reforms is based on the belief that this is the cost-effective way to promote sustainability. That's number one. And number two, the core of the new initiative, Healthier Singapore, is to empower individuals to be responsible for their own health behavior and health outcome in order to promote a more sustainable medical system and social system. Yes, thank you.
Thank you. And Henk, you have the last word.
Well, in my country, Communities are more sustainable, I believe, than government. So that's a big issue. So, and a lot is being done as pilots and as experiments, etc. While regular care goes on, and no one questions it. So I would be, and if we want to make this development sustainable, I think we should also question regular care and give room to small communities. Thank you.
Thank you. There's another question in the chat for Karla. Karla, I don't know whether you're already busy typing an answer, but I'm also happy to link the two of you. But we will share all the resources for the Programa Mayor Cuidado as well, and from the other speakers. This has been an amazing session. I think it really gives us hope to see that so many innovations are happening, because many of them are growing. The evaluations that have been done look pretty good. So I do think that it's really important to pay attention to this, and also to understand that community-based care also requires an infrastructure, and it's really interesting to see all the anchoring in community, meeting centers, in technology, and also how to integrate this with the wider health and long-term care systems. So we're going to have a break. Some of us have already been online for a while. We're going to basically, you don't have to leave, you can just mute and maybe close your cameras. We will put a notice. We are going to start on the hour with the financing with a focus on low and middle income countries session that has been organized by the WHO Center for Health Development in Kobe. Thank you very much. The chat will stay open, so you can keep sharing, and we'll see you in a few minutes. Bye.